Excellent. Welcome everyone to the pitch presentation session. We are so excited to have gotten to this point in our hackathon. I'm Tracy Green, I'm your host for this last session. We're joined by our panel of judges, whom I think you have their bios and see who they are. And we're really excited to see some of the presentations. We have an initial team that would like to go first, and that is the Naloxbox Plus team. So I'm going to invite a representative from the team to come up. Judges, I think you have your criteria and your rubric. And so I'm going to invite Leo Kobayashi to the stage to go first. Let's see, I think, here we go. And just a reminder for presentations, if you have slides, the present to audience, the little arrow down at the bottom, you can click that and it'll navigate to your slides to share. Welcome, Leo.
Hello, how are you? Can you hear me?
We can hear you, yes.
Okay, and I'm not sure, oh, you know what? Let me get my video up. Okay, hello, how are you?
Hello.
So, thank you for having us here, and sorry to have to try to rush this. As you can see, I'm working clinically, so I'm going to try to basically just blow through this really quick. So maybe this will be like one of the fastest pitches you'll hear. It'll be like hopefully like 2 minutes or so. I'm just trying to get the slideshow up and running, so give me just 1 sec. Okay.
Sure.
You can still hear me okay?
Great.
Okay, and let me get the presenter view up. It says loading. Okay, let's go back. Okay, can you see the slides? I'm sorry, I can't share. I can't see the rest of your screen. Can someone verbally tell me if you can see the screen?
We can see it now. Looks beautiful. Thank you.
Excellent. Good. All right. Okay. Good. So thank you all for coming. We're going to present this idea of Naloxbox Plus. It's the idea of having an automated supply monitoring system for community naloxone programs that will leverage IoT due to its emergence and relevance. So thank you to the COBRE Center for helping host this hackathon so we can present. I have a small company that has some of the IP, and then Rhode Medical Reserve Corps and DMAT, the Disaster Medical System team, have been instrumental in getting this idea to start. This is the team. Dr. Capraro, as you're all familiar with, he might be in on the call. And then Brooke Lawrence is part of Rhode DMAT. They basically help organize public health and public safety interventions. And then Ashash Gohil has been doing the UI UX design for this particular presentation. The core problem is that there exist a variety of mechanisms by which naloxone is made available to the community. The issue is that there is a challenge with respect to maintaining that supply when it's actually needed. As part of the solution, the Naloxbox team has previously created a system that can provide publicly accessible and highly visible naloxone storage locations. The problem with this particular system is that it is very manually intensive, labor intensive, in order to keep the supply intact, as there is currently no mechanism to know if the Naloxbox has been opened or if the naloxone has been used. There's basically no metric, no indicator, except just literally checking the box. So what we propose is Naloxbox Plus, which employs and leverages existing infrastructure of IoT to provide hands-free supply monitoring to ensure critical supply in critical times. The concept has been reduced to practice. Naloxbox, the actual original box without the IoT element, has been already distributed to 1,800 owners, and they have been distributed all over the US. And so the actual infrastructure for the physical element is already there. The proposal is to add on IoT elements, which have been, once again, reduced to practice with fully functional prototypes that can provide cell-based IoT hands-free monitoring as to when the box has been opened. It can provide additional data. This is just a concept, a web portal, in terms of what the interface might look like for the owner user. And so that's a critical differentiation. The user of the naloxone is differentiated from the owner user of the box. And we are attempting to reach the owner user of the box. And so they would basically have a portal that they can look at to see, A, if the box has been opened, if so, if it's how long it's been open for, and then to see also when the naloxone inside is expired. So these are current data points that are handled manually, which could potentially be provided automatically through IoT. I think the key idea, which is novel, separate from the IoT element, is that this provides a research mechanism. And what I mean by that is, in addition to basically providing status updates on the box, we can provide additional portals that can then acquire use data for the naloxone. So the owner user could then access the naloxbox using QR code, and then they can provide information about the circumstances surrounding the use case, as in who responded. Did the patient require intervention? Was naloxone used? Was it expired? Did they need more? Et cetera, et cetera. These are all data points that are currently not available, especially from the Loxbox. And so we basically have a deployed infrastructure from which we cannot currently acquire any data, and this will add intelligence through IoT. A quick comparison to existing mechanisms. So the Loxboxes currently come equipped with standard tamper locks, which are the plastic tamper indicator devices. They are obviously not connected. They cannot provide e-notifications, whereas what we are proposing can at relatively cheap price points. And there are other alternative approaches, but they are not fully compatible with what we were proposing. So we believe that there's a novel use case and potential market for this device. In terms of immediate next steps, we have a 1 month target of basically having the fully functional system that has a portal that can be accessed. And then we're going to start building on that in terms of acquiring additional data and then expanding on its capabilities and functions. With respect to the hackathon, the immediate ask is the request for the opportunity to apply for additional funding so that we can do a pilot installation of approximately 50 to 100 devices in the Metro Providence and Rhode Island area to see if this concept has traction. So that's the core presentation. And as I said, I'm sorry, I'm working clinically, so I'm trying to be brief and short. So I'm going to open this up to QA unless Ashesh or Jeff, if he's in the audience, has anything to add. Thank you.
Thank you, Leo. So judges, I think you are all here. Can you please post your questions in the Q&A for our presenters here, Leo and others who might be there on the team? Yes, you're getting virtual claps, Leo. Any questions from the judges?
Hi there, can you hear me?
Yes, we can hear you, Jake.
Oh, wonderful. So really interesting idea. And, you know, I like how this follows on some other IoT applications. What is the business case here? Who's paying, and how do we make sure that this becomes sustainable over time?
Great question. And Leo, if you are, I'm not sure if you're able to go back on, but if you are, awesome. If not, then maybe the chat or the Q&A function might be a good place to respond if that's easier.
Okay, I'm sorry, here I am. Sorry. Yeah,
stay on if actually speakers as you're presenting, stay on. Yeah.
Okay, good. All right, so yes, the core idea in terms of business model is that Naloxbox, the regular Naloxbox, which is the non-IoT enhanced version, is already a product which has been distributed through Rhode Island DMAT Incorporated, which is a 501c3 organization. They are basically a public safety organization, and they do disaster relief, and they also do public safety. They have basically taken upon themselves using state funding to fabricate and then distribute these boxes. The immediate next step from a business perspective is to essentially work with them, collaborate with them, and develop a working model that basically is an aftermarket addition to the existing Nalox boxes. Once there's a validation of utility in real-world application, the plan is to basically add an aftermarket module to the Nalox boxes as an additional product, which would then pay for itself. So the idea is that this will be a commercial product that goes through an Nalox box as an add-on, as a feature to the existing Nalox box system. with respect to immediate next steps, with hopefully additional possible COBRE funding, the idea would be to do a pilot installation and then deploy approximately 50 to 100 of them with grant funding with approximately a 1-year data plan. That would basically provide incentive for essentially a research protocol that would distribute these devices and then acquire real-world data, which would basically run for a year. And the incentive would basically be having these devices provided to the 50 to 100 sites in exchange for data.
Gotcha. And just a very quick follow-on: how do you deal with issues of consent, if you're doing research in the field?
Right, and so we have an existing IRB at Brown and Rhode Island Hospital, so we can use them for the IRB element. This would basically be so the individuals who would be being queried and who would be providing the data would be the owner users of the box, as opposed to the users of the naloxone. So these would be identified individuals who are registered in the naloxone owner system, so we can actually have consent from them to do a study moving forward. That can be part of the agreement in exchange for providing the Lockbox Plus.
Can you hear me?
Thank you.
Yeah, Anita,
Okay.
you have a question
Hello.
as well. Thank you, Leo.
I had a question. So for long-term use, who do you think would or envision being the people who would be monitoring this and then responding to, if the naloxone is used to sort of quickly address, the box and attend to it? And also, just to clarify, the QR code, though, was for the end user of the naloxone to be able to talk, that was the piece I wasn't sure who was using the QR code.
Right, so I'm going to try to answer those two specific questions because they're two distinct issues. In terms of long-term use, the idea is that this would provide real-time online information to the owner of the box, and so they would be the ones who would be maintaining this. Because right now, it's literally a black box, or technically it's a transparent box, but it's a black box. We don't know if these boxes are being used, if they're being vandalized, if they have any naloxone in them. We just don't know. There is a parallel study ongoing that is attempting to basically cold call the owners and see what the current status of these devices is, but that's still ongoing. That's going to take a couple months. But in the meantime, my understanding is that there is literally no end user feedback available at this point. So just deploying these additional boxes with the IoT component will essentially provide a crowdsourced research network and that can provide additional data. So I think that's how I would address the first question. Can you just repeat the second question again so I make sure I answer?
The QR code that is on the box, that is for the person who's administering the naloxone, correct? Is that, or did I misunderstand?
No, actually no, because we specifically wanted to avoid any semblance of surveillance to this particular offering. So we don't want, we'd be more than happy to accept data from them, but we're not actively soliciting input or feedback from the individual who uses the naloxone. There are multiple reasons for that. One is the surveillance issue. In addition, my suspicion is that the circumstances in which someone would use naloxone would be quite stressful and difficult, and have lots of other activities that will be required to keep the patient alive. And so we don't want to impose on the responder to have to do a QR code either during or after that. And so the resolution, the quality of the data might suffer because we would essentially be using the box owner user to supply information. And there very well may be missing data points. But it just, unfortunately, I think that's the best compromise we can reach in terms of the practicalities of studying this in the real world. Does that answer your question?
Yes, thank you.
Okay.
Great. Thank you, Nita. And any other questions from the team of judges? Please raise your hand, go in the raise hand section or post it in the chat. We're learning and getting used to how to do this. So if not, thank you very much, Leo. We have, we'll be chatting. Good job. Yeah. Virtual.
Okay. Thank you very much.
All right.
Yeah.
Good luck. All right. I think the second team, John is coming on. Yeah.
Yeah, I'm coming on. How do I get it on the? How do I get
Your
my
slides,
Yes.
the little arrow button that's kind of next to your microphone at the bottom there, that'll share your screen and you can tell us, point it in the direction of the slides.
Okay. 1 second.
No worries.
Okay. And how do I move the slides forward?
Just like on your normal screen.
I'm gonna try it once. Oh, okay, down there. Okay. All right. Let's see. Where am I? Okay, good. So, hi, I'm Dr. John Su, CEO and co-founder of the Ipil. I would like to thank the COBRE and organizers for putting on the hackathon. It's a great idea. Harm reduction is very important for us. I'm a practicing anesthesiologist, chronic pain management physician. On our team is myself, Sherry Shea, who's a toxicologist, and Athena Su, who is a OBGYN resident at this time. In my practice, one of the biggest things I had as a problem was many of my patients could not get treatment. And if they got treatment, I wasn't able to monitor how they were taking their opioids, which really prevented me from individualizing care so that I could make care successful. The need for treatment is important. There's 190 people who die a day from an opioid overdose. There are 2 million people in treatment and 20 million more people who need treatment, but they have a difficult time of getting treatment. We have to concern ourselves with abuse, sharing, OUD, and overdose. The problem of difficult access to outpatient OUD therapy is that patients can't find OUD information. They can't find an OUD clinic. They have trouble finding insurance. They have trouble getting to the OUD clinic. Doctors and pharmacies at this time don't want to deal with opioids because of increased litigation from the opioid litigation that's costing billions of dollars. There's an increased time and resources necessary to treat these patients. There's X waiver limits. And really, the most important part of it is there's no prescription adherence monitoring. Patients can take 1 pill or they can take 10 pills. OUD clinics are full. They're underfunded, understaffed, and they're expensive. And the result is a high relapse rate. 27% of patients relapse on the first day after therapy ends, 65% in 30 days, and incredibly, it could go as high as 90% in 1 year. The real problem is MAT therapy. Only 1/3 of OUD clinics use MAT therapy, despite the fact that MAT therapy reduces opioid overdoses by 50%. The issue is there's no harm reduction at home. 1 in 4 opioid overdoses today involves children and teens. Hospitals triple lock opioids at home. Yet these same opioids are not locked. They're often left on the kitchen table at a patient's home without any security. So the solution is to secure opioids at home, just like in the hospital. OUD starts at home, not in the hospital. Our product is the Ipil Dispenser. It's a drug vault. And if you really think about it, it's a bank ATM for pills at home. We destroy pills on tampering, and we dispose of unused pills. No more flushing down the toilet so that oysters in the Chesapeake Bay get oxycodone. The Ipil app is a biometric key. We use 2-point biometric authentication, a face print or a fingerprint, and a personal code. That means that only the patient prescribed has access to pills at only the prescribed dose and time. Our product line is for 2 purposes: pill security and patient safety. The Ipil Dispenser and app together work to reduce misuse, abuse, and diversion. The respiratory sensor, that's a small Band-Aid that fits on the chest to record respiration and tidal volume, connects to the Ipil app to detect opioid-induced respiratory depression. If that occurs, the app calls 911. We need to control the pills, and we need to save the patient. The Ipil has 3 granted patents in the United States, and we have PCT patents in other parts of the world. We're Class 1 registered, and we're incredibly a FDA breakthrough designation. This is important because only the Ipil will be covered by insurance, which means that because Medicaid is a major payer of OUD treatment, we will make it so that patients can get treatment with Medicaid and get the Ipil and get MAT therapy. The market for the Ipil is huge. It's $2 billion per year. There's 14,500 OUD clinics in the United States, and we already have current traction. We have 2 purchase agreements from OUD clinics. The business use case, customers want the Ipil. Currently, OUD clinics that use methadone use a liquid form to reduce diversion. To get patients to the clinic, it costs $20,000 per year per patient. And many patients can't afford it. So they just don't get treatment, especially in the rural areas where an OUD clinic may be 30 to 45 minutes away. Using the Ipil, we can reduce and eliminate most of the transportation costs because we can send MAT therapy drugs to patients' homes. We're a secure dispenser. The FDA has approved what we're doing. We can get patients access to MAT therapy. So what does the OUD clinic have to gain from all this? They save on operating costs. They can generate more revenue by using remote patient monitoring codes. That means $300 to $400 per patient per month in addition to what they're earning now. They can increase value-based contracting to become more profitable. The second use case, everyone's talking about digital health, rehab in place in COVID. Well, that's good, but you're only taking care of the patient. You actually need to take care of the pills for harm reduction. These digital healthcare companies fear litigation because there's no harm reduction in the inability to monitor home medication adherence. Using the Ipil, they get that, and they get more revenue. They get medication adherence, they collect data, they can improve care, reduce relapse, and litigation. It's a win-win situation for stakeholders. Patients, pharmacies, clinics, insurers, everyone wins from this. Pain has many sources. We need to take care of the patient, and we need to take care of the pills for home harm reduction. And I'm going to leave this slide up there because there's a lot on there, and I can answer questions as you review this particular slide, because harm reduction is very important, and all the stakeholders need to understand that we all need to work together. Thank you very much.
Thank you, John. Judges, if you could please go to the raised hand function or post your question in the chat for John. See, Jake has a question. What are you can see on the screen there. What are the legal liabilities?
So
what are the major risks?
Two things. Right now, anytime you prescribe opioids, there's an opioid litigation. Right now, the national opioid litigation against pharmacies is billions of dollars. For physicians, if a patient overdoses, I can be put in jail. I can lose my license. Okay, beyond, what are the major issues the business you see for the business in the coming year? We're coming out to commercialization in Q1 of 2022. So we're commercializing with production. We're using Foxconn, the makers of the iPhone, for production in Mexico. We're probably going to connect as a strategic partner with either Omnicell, who make hospital-sized vaults, and or Pyxis, which is owned by Becton Dickinson, to get these products out to market. One of the biggest problems we see for the next year is education. People are going to think this product is expensive. It's not. It's very inexpensive because we're making it so that people can afford it. The second thing people are going to worry about is no one has a smartphone. Well, 85% of the US population has a smartphone. If you don't have a smartphone, we can arrange for you to get a lifeline phone through the Obamacare CARE Act.
Right. Anita, looks like you have a question. Oh, we lost John.
Oh, is he there? Or no?
Let's see. I think we need to get him back on.
Here.
There we go.
Hi. So I'm a pharmacist, so I'm curious about the structure of the mechanism, how it's loaded, how it dispenses the pills, labeling requirements, like ensuring, expiration, like there's not expired product, and just sort of the details from like a pharmacist perspective.
This is the cartridge that destroyed pills. The cartridge can change size and number of pills, up to 120 pills. The prescription starts off with a QR code. Every prescription needs a label. We'll put the label on the QR on the back of the dispenser for size purposes. This is my phone, and this is the Ipil. The QR code sends the information to the app. So the app makes sure that the patient is prescribed, and then the prescription is in the app. So it prevents anyone from getting more drugs than prescribed at the prescribed schedule.
But the pill is being released from that box for the patient to then, okay, yeah. And so it holds, you said 120 tablets?
Yeah. Okay. So I'm going to give you something in the future to think about. This is not just for opioids. This could be for tranquilizers, sedatives, ketamine, stimulants. If you think about this as a souped up child-resistant cap, where the child-resistant cap, you can open it, kids can open it, and you get access to all the pills. Well, with this, you only get one pill every 4 to 6 hours, or in the case of methadone or Suboxone, one pill once a day or twice a day.
Gotcha. And it's clearly very secure. I guess it's metal or...
Yeah, in 30 seconds, it's plastic.
Okay.
It's plastic is because it's for the cost. I need to make this as inexpensive as possible. The differentiating part between this and any other dispenser is that we destroy the pills inside upon tampering. You take a baseball bat or you drop it from higher than 6 feet, the pills inside are destroyed. At the end of 30 days, the pills are destroyed because of the Drug Supply Chain Securities Act. Anything that touches an opioid must be destroyed after 30 days. Or must be destroyed after use. And we elect 30 days because I see my patients every 30 days.
Gotcha.
As far as the pharmacy goes, we're going to do this B2B, meaning that we're going to pre-fill it, and then we're going to send it to patients directly to their home or to the clinic for B2B sales.
Thank you.
Thank you very much for your question.
Great. And it looks like you had a couple questions here. Just clarification from John about wouldn't you be another player to sue in terms of legal risk?
That's completely true. But if you look at the child-resistant cap, they're not being sued. We're a this child-resistant cap was designed by Dr. Henri Briault in 1967. There's been no updates since that time, 54 years. We're a device. We are a upgraded box, so to speak.
Mm. Let's see. Brandon Marshall was asking, can you clarify how the Ipil machine destroys pills? Are there any potential safety issues with that mechanism?
So there's a DEA-approved solution that once the solution touches the pills, there's instantaneous destruction or dissolving of the pills. It's not toxic. You can actually drink it. We actually use the solution sometimes down what's called a nasogastric tube to go into the patient's stomach to deactivate different poisons. And there's another question in the from Lifespan about people who are homeless. This is designed for people who may not have a home or may not have a cell phone, because we can arrange to have a cell phone sent to a homeless person. We can give this to a homeless person, and we need to use social work to help them learn how to use a cell phone and connect the app to the cell phone. It's like online banking.
Okay, that's helpful. And Laurie McDougall, I'm going to go through these a little bit more quickly. They're not from judges, but from people who are in the audience, which is important too. Is there any information, feedback, research from the patient or possible patients and their perspectives of this product?
Sure. We did a focus group with dental patients, young teenagers, and they were really keen on using it. The teenagers' mothers really wanted to buy the device. They wanted to pay out of pocket because they have other kids at home and wanted to prevent danger to the other kids. So we gave it to a group of 10 teenagers who were able to use it. These, I shouldn't say teenagers, but they were varied from 25 to 55-year-old people for wisdom teeth extractions.
Okay. And it looks like Matt and Peach are asking similar questions about involvement of thinking about more along the lines of illicit supply and illicit drugs. How does this address the challenge of fentanyl in the drug supply? And then similarly, in talking about illicit use, has there been involvement of active and past drug users in the development of this product?
Active and past drug users, my patients. I gave it to my patients to use at home. And they liked it because it protected other patients, other people in the household, number one. Number two, some of the past users said that if they had this device, they wouldn't have abused prescription drugs, which because of opioid restriction left them to fend for themselves and go to illicit drugs, which are cheaper and easier to obtain. 86% of heroin users report first using and abusing prescription drugs as teens. So we start at the gateway. You prevent the gateway, you prevent illicit drug use.
All right, I think for Matt and Sage are asking similar questions about the illicit supply and sort of thinking, and this will be the last question because we do have other presentations. So just clarifying about how this approach is addressing a safe supply, considering this would be for prescribed and through medical routes. How do we address the larger, like, might it actually create more push towards people going to an illicit market if they can't get it out of an exploded pill box? Is that I think what I'm hearing and seeing here.
So what we really want to do is get patients treated for both pain and OUD treatment. I actually want to give opioids to patients so they get treatment, so they don't go from prescription opioids to illicit opioids. And it's very important to do that because studies are now coming out saying that the restriction of opioid use, cures, REMS, has actually increased opioid overdoses because they're going to illicit drugs. We need to get patients treated for pain right away and be doing it safely. The illicit drug situation needs to be controlled by controlling the gateway, the abuse of prescription drugs as well.
Great. Thank you so much for the presentation. We have a third group that's going to present and take the stage. Let's see, and I think that's the Recovery Works group. If you want to, you were third with requests. Senator Miller, your great question is one we can probably take in the judges' room afterwards too, and follow up on that.
Hello.
Welcome, Sarah.
Actually, it's Keon. I would have been there on my laptop and on my account, but my laptop died. So, accommodating.
It's a long way to Waterloo, so we have to we're taking our time.
Hello? Am I audible?
Hello.
Do I just share my screen like this?
There is a little arrow on the bottom part next to the microphone. If you hit that, that'll share your screen and you can tell us where. Awesome, there it is.
Cool. So I'm just good to go?
Yes, welcome.
Great. So, one second. I just got myself a timer here. All right. So we have an educational app for employers to develop recovery-friendly workplaces. Now, the problem area that we're focusing on is opioid-related loss of work hours in businesses. Rhode Island lost $1.4 billion for substance misuse-related reasons, and 900 million of that was lost productivity in business hours and absenteeism. Additionally, across America, about 70% of Americans who use illicit drugs are also employed. So there's definitely a very distinct need for employers being more geared towards providing a friendly workplace when it comes to having recovering patients or recovered patients. Why does it matter? Well, as it stands, almost 17% of employers are unknowledgeable about the signs and symptoms of OUDs and many of their recovery side effects. For example, methadone has the side effect of causing heavy sweating, which can look bad in interviews and things like that. And this can lead to potential employment discrimination and lack of accommodation where appropriate or necessary. And even past that, it leads to lost productivity, revenue, and more toxic work environments, which can make it more difficult to hold a job as somebody who is a recovering persons with an OUD or an SUD even. In fact, again, in Rhode Island, 1 in 10 citizens have a resolved issue with alcohol or drugs, meaning that, firstly, they're already recovered, they've done the path to recovery, and more recovery-friendly workplaces will promote better productivity, revenue, and healthy work environments, not just for these 1 in 10, but also the 9 in 10 that work with them. So previous solutions that have been put out there is Recovery Friendly Rhode Island, which is an initiative pushed by Governor Dan McKee. It focuses on developing the infrastructure to begin endorsing and spreading awareness about recovery-friendly workplaces and pushes for businesses to become involved in the process, not just of providing a safe workplace, but also for getting people off the streets, getting people into the recovery process, into that path of healing. Our collaboration with this initiative obviously has not occurred yet, but we do fully plan to integrate with them and contact them after the hackathon and whatnot to implement our idea with theirs, as what we have is supplementary to the Recovery Friendly RI initiative. We provide a platform for the employers to both discuss questions, concerns, and curiosities to help get them initiated on the path to becoming recovery-friendly workplaces, or RFWs. And by the way we're doing this is by creating a mobile application, which has a forum format and also many resources such as peer support groups, government agencies that have resources, training facilities and programs that businesses can take advantage of to train their employers and employees on how to create these safer workspaces. And this will allow employers to discuss with people who have already gone through the Recovery Friendly RI program and see what have they done that works and what haven't they done, or what have they done that doesn't work. And this will help get people along the process of becoming an RFW and notify them of the obstacles that they have with advice on how to overcome them. Now, for the feasibility of the project, when you have infrastructure for something in place and there's a project that can piggyback off that infrastructure, the viability goes up. It's easier to start at 60% or 40% or even 20% than it is to start at 0%. That initial cost of putting things up has already been expended. So it wouldn't be too hard for us to just, like I said, collaborate, contact, and get in touch with the RFRI initiative and begin to not necessarily piggyback, but build onto and expand on what they've already put in place. And again, these funding and resources can be sourced from the RFW framework, and that teaming up, I think, is just mutually beneficial for both. And that's what we got. Thank you very much for listening. Let me just head back to this tab.
Excellent. Thank you so much for a great, lots of virtual claps. Woo-hoo! So for your team, judges, questions that you'd like to put either in the chat, or if you'd like to raise your hand, go to the raise hand function at the top and join us on stage for questions for the team. So you could see, but Jake asked a question. What does implementation look like? I would imagine that the more progressive employers are already on board, while others, perhaps the majority, won't engage. What are your thoughts?
So when we're talking implementation, what we really mean is, with something that is on a website, you hear about it, then you have to go home, you have to look it up, and you have to start looking through and everything. But that's all mainly through word of mouth. When we implement our app, when we release our app, right, people will hear about RFRI, and through word of mouth, they will also hear about our application as, hey, if you've heard of that, try this. This is similar. This is, giving you the similar resources. And that's something that an employer who may be part of the majority and probably will be, can just look on their phone, look up the app, download it, and start looking at what we offer and what we're doing, right? And the benefits, such as, no cost program. It doesn't cost them a penny to train their employees. It doesn't cost them anything to start creating these workspaces. And it helps them by increasing the revenue. Like we said, 1.4 billion was lost in productivity, 900 million being through absenteeism. And if there's a big issue with OUDs, which we know there is, having people who can come into work, having people who can work for you more effectively is always good. It's a win-win for everyone, right? Employers get employees that feel more comfortable working with them, employees that will stay with them longer, who will do more for their companies, and employees get a safer space to participate in, to make money from, to have financial stability from.
Any other questions? Lori would like to take the stage with a question.
Oh, no.
Here she comes.
No.
Uh-oh.
That's okay, Lori. Unfortunately, within the time frame that we had to develop our project and to do research for our project, we weren't able to find any sources for whether or not working while in recovery consistently is beneficial. But this doesn't have to always be in recovery. It can be after recovery, but you can have a history, right? And this helps destigmatize patient history, right? Let's say, I've been an opioid user for 4 or 5 years, and then after 4 or 5 years, I decided I want to recover. I'm gonna take methadone, or I'm gonna do abstinence, whatever works for me. I'm along my path of recovery. I'm at a point where my life is relatively stable, but I want to get working again. I can show that, or I'll be lucky to go to a business that understands, all right, just because I'm on the road to recovery doesn't mean I'm unfit for work. Doesn't mean that I can't work. And just because I've had to recover doesn't mean that I'm unfit for work either. It'll be educating them and reducing these preconceptions that people aren't capable, and instead show them how capable they really are.
And I guess just to clarify, do you all envision this being something that could be for harm reduction friendly workplaces, as well as, I don't know if the concept of recovery is full continuum or medication based, or just to clarify.
Yeah, it definitely works for that. And another thing that also would help is, when we implement an app like this, you can always start a pilot study. You can always begin to do the research yourself if it doesn't previously exist, to see, how successful they are. Because obviously we can get feedback from employers like, hey, this employer hired 350 people over the course of the last 4 years that were on the path to recovery, but weren't necessarily at the end of it, right? We can see how long do those people work, how successful and productive they were, and then we can have information on, the numbers. We can have the numbers. And Leah, you're absolutely right. There is no end to recovery, but there are definitely stages.
Anita, welcome.
I'm nervous this might be a little bit of a silly question, but what can you just explain a little more details about like what is in the app, like what the app entails? I don't know if I'm just like not fully grasping it.
So in the presentation, we did have some mock-ups. If you want, I can share the screen again. We didn't get all of the photos in. Unfortunately, we just couldn't find the space to fit them all in. But my group member, Zay, can actually jump in and start showing you the mock-ups. He has access to all of them. So if you want to do that, we could do that.
And you could just describe a couple of the areas as a net.
Sure. So one of the things is, you know, you got your classic mobile or your phone, you know, the rectangle. Everyone's familiar with that. And you would have, you know, somebody, if you're looking at my hand, you know, we got this going on. They'd ask their question here, and then other people would be able to respond underneath. There would be like a home page that lets people look at other questions asked. Like maybe there's a topic of interest they'd like to search up. They can do that. And, you know, find if someone else has asked that question before. There are resources that they can access. There's an FAQ for frequently asked questions. There is pretty much a resource dump of, you know, links that they can click, organizations that they can contact, things like that. Things that can help them support their employees better.
Yeah, I mean, if you want, we can show the mockup app. Otherwise, you know, no need to. So what do you guys think? Should I show the mockup or?
You know, just in the interest of time, maybe we won't look at them, but I think your description was wonderful, and it's amazing to think that you have mock-ups of them. So this is great. Let me just check in and see if anyone has any other questions for the team, and then otherwise, great job. I think you've got some lots of applause. Excellent. Okay, team. I think the next team that is ready to go, Brendan, Jacka, you are going to come join to share about Access Express. Oh, Lori's coming.
Yep, I'm going to get us started.
Excellent. Welcome.
Started. So hi, everyone. Our team consisted of Brendan Jacka, who is a researcher at Brown University, Leah Germanara, who is a certified peer recovery specialist with Oasis Wellness and Recovery and NAMI Rhode Island, among other wonderful titles, and myself, Laurie McDougall. I am the REST Family Program Manager at RICARES. I'm hoping, actually, we have a slideshow that we would like to share. So, and Brendan is in charge of sharing his screen.
Brendan might need to come to the stage too,
okay.
To do that, unless you have the slide deck.
I do not. I was unable to share my screen for some reason.
No worries. We've got you. I think Brendan will come on stage shortly. Welcome, Brendan. When you're on the arrow function one is the share screen. Just click that and navigate to your screen. Excellent.
Okay, so we are calling our project Access Express. And just to give you an overview of what the problem is, here in Rhode Island, we're hearing more and more about deserts to describe how certain locations are missing basic human services. Whether it's digital, food, or human services, there's an awareness that this imbalance exists in many settings. As expected, services are generally placed where there is highest demand. So just for example, if you look at the picture that we have here, this is taken off of the Prevent Overdose RI website here in Rhode Island. And the deeper red areas indicate the highest concentration of overdoses. And then the other colors, actually, as they spread out across Rhode Island, the overdoses still exist, they're just not as highly concentrated. So certain areas have a high concentration of overdose in Rhode Island, but no part in Rhode Island has no need. Next. Getting harm reduction supplies can be hard. Services are often limited to certain hours during the week, and really life does not happen between 9 and 5. For various reasons, people are also looking for anonymity. Next. Funding for harm reduction supplies are severely restricted. Next. Community outreach workers are overburdened with work, and community organizations often have like a stockpile of harm reduction supplies, which is why we are looking to, and actually, why don't we go next, Brendan? Why don't we go to the next slide? Because here's our solution. Our solution is to democratize harm reduction materials. It's a network of 24/7 access to harm reduction dispensaries, paid with paired with a community engagement hub. Also giving communities the opportunity to determine what is going to be in the dispensaries. So it's kind of targeting the communities or making them very community specific. From here, I'm going to hand it off to Leah.
Good afternoon. Thank you everyone for your time. So what we've done is we've developed a website which would give us an idea of what we could add to the outside of this vending machine idea. It could have QR code connectivity, location mapping hub, community resource. Let me just show you. Brendan, can you press the Access Express website, please? So this is just a basic prototype of what it would look like. When someone is to access our material, this information would be there, and they could connect with resources. They could request a hub in their neighborhood if it's not there now. And Brendan, could you go to the next page, please? The location. Thank you, sir. This would, so we thought about the idea of partnering with other folks in the community. So of course, our other community agencies, I'm sure we could, reach out, talk about, cutting down the cost. We're all buying the same stuff. And like Lori was talking about, sometimes there's an overabundance of certain things. We could share materials and use them for vending machines, perhaps partnering with CVS, Walgreens. We would have a location hub where people could, again, scan that QR code, visit a website and say, and see where they could visit a hub in their area or a portal. If you could go to the next page, please. And then, of course, community feedback is essential. This is a community-based public health initiative. The idea is that we want folks to have a place to come to say, we need this product, we need a refill of this, we'd like one in our area, or if someone would like to request a modified pod. There are different needs in different areas. And the idea is to give people, again, that 24/7 access. Our peer workers, our community health workers, our outreach workers are inundated and overwhelmed. The funding is not available to keep people available 24/7. But if we have access to these in various locations throughout the state of Rhode Island, it would give people a little bit of dignity and safe access to supplies to keep them well and safe while using. Thank you.
Fantastic. Can you hear me? I don't know if...
Yes, we can.
Super. Thank you, Laurie. Thank you, Leah. So I have appreciate the introduction by Laurie and Leah for the setting and the solution. Leah has the community and the organizational connection. And then I'm going to share some information about the physical product. So for folks that are not aware, vending machines for harm reduction materials are not new concepts globally. They've been in Europe and Australia and Canada for about 30 years, but very, very recent for the US. Puerto Rico's had a vending machine for about 10 years. And this is an example of the machine in Las Vegas, which is quite new. we believe that the vending machine displayed here is maybe not great for anonymity. It's colorful, it's bright, it's, you know, almost say attention seeking. And so we came up with an alternative, which is kind of smaller, compact, transferable version that is kind of a low-tech option. So the de-harm dispensary, as we're calling them, so it's the democratization of harm reduction machines, is based on technology or thoughts that we already have. So folks that use laundromat know about a coin-operated machine to get their soap, to get their detergent, to get their bleach. So we thought of a machine similar to that, a simple turnstile. You put in 1 or 2 or 3 quarters maybe, and then through a process, a low-tech turnstile, folks are supplied with the materials they want. We came up with kind of a modular system. So the second image is kind of a demonstration of how the product would be stacked up, and that would help us with the back-end operations. So the individuals that are restocking these supplies would just grab another pod and put it in place. The third image is to demonstrate the flexibility and the scalability of the system. So for different communities that are smaller or with lower needs, could start off with 1 or 2 pods, and then they could add extra pods as they require. So as Leah described, they could request a new pod, for example, a basic needs pod that has soap and socks and toothpaste, or a safe smoking pod, safe smoking supply pod. And finally, the last image on the right is an example of a safe consumption material. This is called a fit pack, but it's essentially supplies of syringes and a safe storage. And this is an example of one product that we wouldn't need to recreate, but we would find ways, or it would be the vending machine would be produced in a way to use currently available materials. So we would have packets or boxes of syringes, packets of fit packs, safe snorting and safe smoking materials, and then, as Leah suggested, more basic needs materials, sanitary products, for example. So really the idea here is that by creating a simple but modular system, communities have more input through their local organization to make it responsive to their needs. And that's our presentation. Thank you.
Great job. Great job. I think our judges likely have some questions. I think there's some, please use the raise hand function. Looks like Brandon, you have a question. I think you can take the stage. We're still figuring out the technology here, but it might bump one of you off if it does. Sorry about that.
Let's see, can you hear me?
We can hear you.
Great, thanks. Great presentation. That was very, very cool. Wonderful project, Lori, Brendan, and Leah. I might have missed this, but I was just wondering how you would determine where the harm reduction vending machines go, or would communities request them and then they would be installed? If you could just talk a little bit more about how you'd select locations, I think that would be great.
I think it could be a combination of, like every project, it takes time. I think we could certainly collaborate with our community organizations. And guys, please jump in. Absolutely.
Yeah,
Brendan,
no,
Lori.
I agree with Leah. I think organization of or where are we going to place these vending machines or dispensaries? I think it's a collaboration with who is going to monitor them, right? And then using that access to kind of determine where they're best placed. And we did have discussions about whether we can have these vending machines outside, right, inside, and do we need to have something that is maybe battery operated so that we have what's the word, like if we have Narcan and we have to keep the temperature of the particular vending machine at a certain level, and just kind of brainstorming how do we adjust for something like that. I think there's actually multiple ways of finding places to put these vending machines. Again, also allowing for community input, right? Where does a consumer of these, or someone that's going to go and access these supplies, where would they like to see it? So we had a big discussion about it.
And also on the prototype website, we had put in areas, and again, just a prototype, but where people could go in and say, hey, we'd like one of these in our neighborhood. Hey, we have a need for this. With a drop-down menu, they can certainly contact. And, at that point, I think, we could collaborate, work with other people. We talked about CVS. They're a Rhode Island company, perhaps collaborating with them. Walgreens, different healthcare agencies, so on and so forth, just to get things started and slowly moving outward.
Thanks so much.
Thank you.
Great work.
One other thing that we just thought it would really help with, we had learned that information on the very first day that people of color or communities of color, a lot of people won't carry Narcan on their person. And we just thought, wow, what a barrier, right? And how this might just be able to give access to people who need access to harm reduction supplies without having to always have it on their person, if it makes sense. We just thought it was such a great way to kind of address anonymity, barriers to going and getting supplies at the pharmaceutical, at a pharmacy. It just kind of takes down a lot of the barriers for people.
Public health initiative, keep people safe.
Mm-hmm.
You have a question from one of the judges asking, how would those using the machines know about the availability and placement if they did not have access to the website or to smartphones?
I think I might jump on this one if it's okay. I think this is a fantastic question. The goal that we're going for here is word of mouth helps, but we want the machine. One suggestion is that these machines would be out in the public and open, but kind of visible for people that need it, but invisible for people that don't, to kind of remove the stigma around using it. So that's why we envisaged simple machines that are not full of lights and color. So it would be through pairing with local organizations such as RICARES in their kind of area, and they're communicating to their clients and word of mouth through the community. The apps and add-ons, but we wanted to keep this as simple, as unrestricted as possible. So 24 hours, 7 days a week, and without registration and just coin use, essentially. So the phone requirement is minimized for this material.
Cool. Another question from the audience here. Tobin is asking, wonder if you thought about other ways for people to access the products beyond quarters money as the input.
We discussed this quite a bit. I do believe, like I was saying before, we have a great community here in Rhode Island, a lot of, collaboration, and there's a lot of overspending. I think we could certainly try to budget together. I think we could also work with our healthcare agencies to get donations. We discussed sponsorships at one point. Businesses love to have their name or their logo put on something, possibility of having some kind of collaboration there. But funding is, please guys jump in. Funding is certainly something we discuss quite a bit.
Absolutely. And on the individual side, I think to answer maybe a different way of Tobin was asking was, we could provide tokens that could be used that harm reduction providers could distribute, but that requires individuals knowing about the harm reduction or being willing to access the harm reduction organization in the first place. So we could organize a free version, but there's in some cases issues with people taking it without need. So to be determined, like we're very flexible to that. Any kind of way that gets these materials out is the best for us.
Excellent. Let's see, a question from here. I might have missed this, but is there an estimate for upfront costs of machines and products?
Absolutely not. This is really just the beginning. We haven't got that far.
We certainly talked about it and looked at other ideas and other initiatives that have happened. I mean, we would love to keep the costs down. Obviously, that would be the hope, to have the less money spent, the better, with the more outreach that we could do. But it's a step at a time.
All right. Gordon has a
Canadian
suggestion.
loonies.
Yes, donation of coins from Canada. Excellent. I think that we probably should move on to the next team. Thank you guys very much for the presentation. And just teams, a request. I think if you haven't seen it, maybe you guys were in the middle of presenting, didn't see it, but if you could send your slides to Michelle Diorce, her emails in the chat there, just so that the judges have it for reference when they're chatting. Okay, let's see. The next team. Heal on Wheels. Are you ready to go next? Yep. Looks like you're in the lineup. Okay. Welcome, Amanda and Ashley.
Hi, everyone.
Welcome. Do you guys have some slides you want to use the arrow button to share?
Yes, Amanda, do you want to pull those up? Amazing.
All right. Welcome. Introduce yourselves.
Hi, everyone. I'm Ashley. I am with the research team in the emergency department and Lifespan. And we have a few other team members. Not everyone's on here right now, but Amanda, if you wanted to introduce yourself.
Amanda, you might be on
I think she's on
mute.
There
Hi,
you go.
sorry about that with the two screens with the sharing, it wasn't working. But yes, I'm Amanda, part of the team Heels on Wheels. I'll be helping out with the PowerPoint, but really excited to share our idea. So I will mute myself and pop back over to the slides.
Right. Okay. Okay. Use treatment care could result in discrimination, debt, or deportation. Our group, Heal on Wheels, has set out to tackle this very issue. As a group of EM clinical researchers, OUD researchers, and peer specialists, we have seen it firsthand that there is a gap in care. In recent years, there's been a huge demographic shift with increasing use of opioids and overdose-related death in the Hispanic and Latinx community. Access to care is already threatened by systemic variables, and circumstances have only worsened during COVID-19, including increased isolation, changes in employment status, the drug supply, housing status, and disrupted medical treatment and recovery services. Furthermore, individual components such as the language barrier, historic distrust of government and healthcare institutions, the fear of deportation, shame and stigma, and the lack of education about the healthcare system must be prioritized in the development of interventions. The mobile unit bus that is pictured here is, so what do we do about this? The Heels on Wheels will fill the gap. We will quite literally meet people where they are and provide culturally competent bilingual care to the Hispanic and undocumented communities in Rhode Island. By revamping an old school bus or an RV, we can deploy this mobile service. Our mobile unit bus will consist of an integrative care team, centered providers with people who speak Spanish, live within the designated communities, and have lived experience with OUD. We'll provide health screenings and physicals, promote a holistic approach to health while reducing stigma for those utilizing our substance use and buprenorphine services. On our mobile site, will provide access to laptops and phones, opening the door for individuals to use telehealth care and online social services. This will allow people to meet their continuing care needs without having to leave in their neighborhood. In addition, we'll offer a range of basic need materials from safe consumption kits to hygiene products. Our team of peer and social workers will work as navigators, connecting people to all necessary healthcare, social, and recovery services. Linkage to care. To promote the linkage to care, we'll provide education, resources, and training offered in both English and Spanish. This wall of business card-shaped tools would include resources such as the buprenorphine hotline, safe stations that are dispersed through Rhode Island, peer recovery coaches, a crisis text line, and more, which patients can take home with them when they leave the bus. These couple images here, according to the 2020 census report, 16.6% of Rhode Island is Hispanic and Latinx, and most are located in the Providence County. These numbers are likely underreported, though, because undocumented folks may not be accounted for. This breakdown on the left will guide where we want to focus our hack. This one example on the right of a heat map of EMS runs for opioid-related events in a public space, it indicates that these locations are where our unmet needs are. This next one is the percentage of opioid OD-related EM runs. These charts are examples of data we'll use from Rhode Island drug overdose surveillance to determine the schedule for the Heal on Wheels by specific days of times of the week and also times during the day. A marketing campaign is advertising these on a social media is going to be a very useful component for us. But for those without access to technology, public advertisements will be vital. Emails to partnered groups will be sent out to create awareness for everyone. Connecting with the House of Hope will be an extended tool for creating trust and relationships within the community. Viability. One of the largest barriers to Heal on Wheels is financial sustainability. Our plan, through the help of Business Development Director, is to partner with teaching hospitals and Lifespan, marketing our project as an expansion of their facility. Not only will this allow for the training of more culturally competent practitioners, hospitals will, in the long run, save money on avoidable emergency room costs. Additionally, we will partner with local community organizations who already have these resources in place and that we're looking to offer. Creating this network will be beneficial to keep this site afloat. For all their unmet needs, we'll seek additional funds. In order to create long-term viability throughout research, listening to the communities on the ground, and building relationships and partnerships before implementing this project is necessary. So all in all, with the Heals on Wheels, we are meeting OUD patients where they are and filling the unmet needs of the Latinx community. Thank you.
Lots of claps there.
Thank you.
We're so excited to hear your questions, judges. Please feel free to raise your hand, put your questions in the chat. And I apologize if anyone gets bumped from the stage if we bring people up on stage for a question. But Jake, thank you for your question. How can you prove your financial value to the hospital systems? This could be huge. If you can get them on board to pay even 10% of the value, you'll no doubt create.
Right. So I think that a lot of this stems from the fact that all of us work inside the emergency department, and we see on a daily basis that there are a lot of patients that are coming to these EDs for just needing their basic needs to be met. Of having having a bus that goes into their communities will avoid that problem. That would also lower the amount of people that come to the emergency rooms, and also are, if they're admitted for substance use categories, we will be able to get them in their communities where it starts and avoid longer hospitalizations where they just didn't have the access in their local community and weren't able to get to a place where they could have gotten ahead of time. And instead, it got to a point where they do need to be admitted and they have long-term effects.
Great. Looks like Sage piped up with a comment too. Finding grants to research this and measure that would be helpful.
Yes, and Donovan mentioned the overcrowding of the emergency department. That is a super strong point. They are incredibly overcrowded, and avoiding that will just benefit other patients in our emergency room, but also benefit these patients that are getting neglected in care. Yeah, so what Leah just said about she worries about one transportation unit and a small group of people being able to handle the need. Yes, she's absolutely correct. We have implemented another idea about having the one bus have all of the care and needs on that bus, and having a small little van that would be able to transport these patients if necessary, and have more opportunities instead of once the bus moves, it's gone, and that eliminates a lot of people who are there getting care.
So in that way, are you thinking about like kind of two or one major bus and a small other set of capacities?
Exactly.
Okay. Miguel has a question, a judge asking, aside from language, which in and of itself is obviously important, can you talk about the culturally specific ways you would engage Hispanic and or immigrant groups, and how this differs from other approaches like stigma, encouragement for treatment, etc.?
Yeah, I think we thought a lot about that. I think the big importance is going to be able to get into these communities and build a rapport. That's where the House of Hope, where we realize that they are integrated in communities and they have trust with these people. And simply that, just gaining rapport and gaining trust in a system that has let them down, having something that they can trust by going through people who they already have those rapports with, I think is going to be super important for us.
We have a question from Senator Miller. So have you looked at uncompensated care data created by the undocumented and the savings for potential partners this project could create? I think he's cost savings from providing services.
I haven't. Yeah, what did say talking to me and Juliet's name? Yeah.
Looks like I think his comment was more around like other value propositions, if you will. There might be cost savings from hospitals that charge but don't have. There's no clear payer for folks who come for care who are undocumented. So there might be more cost savings in providing this care in a mobile van environment, because they don't come for more hospital-based and ED-based care. That's a great point, Senator Miller.
That is a great point. Thank you for asking that. I think we've thought about it, but that's great to have there. Thank you. Yeah.
Let's see, any other questions?
Yeah, sorry. The Clinica Esperanza and the Hope Clinic, those are great communities. I think they have leaders that are integrated in these communities, and being able to pair with them and seeing how they go throughout the communities and see where there is the need for a mobile unit like we're proposing is going to be really key for our project. But yes, anyone else has questions? Sorry.
All right, excellent. Thank you, team. Heal on Wheels, this is excellent. And I think the next team is up and maybe ready.
I'm not exactly sure how to.
Don't worry, we got you. All right, welcome, Portland.
Hello, thank you. Oh, I'm on stage now. That's amazing. Okay, I have to set up my screen share. I was not expecting that to be that immediate.
Welcome.
Thank you.
All right.
My Wi-Fi is buffering. I apologize. It's screen share.
Do you want to introduce yourself while we're waiting?
Yes, absolutely. I forgot that I can do things outside of my like time parameters. Okay, so my name is Avi Yocheved, and I am a peer worker at a syringe access program in Eugene, Oregon. I'm also a member of the Portland Drug User Union, which is a citizen activist group invested in the health and civil rights of people who use drugs, specifically criminalized drugs. And I also do mutual aid work in harm reduction in Portland, and I have a background in working on our extensive decriminalization effort that has recently kind of solidified itself in the past year. And let's see if my thing loaded. It did not. Let me reload it. It didn't do this the whole time that I was working on it.
It's no problem.
Would also like to say that my amazing teammates are in the chat. Peachy Anderson and Matt Peterson are both from the organizations that I'm in. Aha.
You guys are welcome on stage if you'd like to come, since we figured that part out in our tech piece. And if not, no worries.
Feel free to come up here. It's very, I don't think it likes that I'm on stage and trying to load a presentation. Okay.
I'm not sure if I just got on stage.
I very
but
much
can't hear
apologize for
anything. I
that.
have no idea what is happening right now. My computer is not working. I'm trying to switch things.
Your mic is working just fine.
That's beautiful. That's a good sign. I'm going to close every other tab and hit present again and pray. I also plug in my computer. That might help.
All right, we might be having a little buffering or connectivity issues. So, all right.
Yeah, I'm so sorry. It's like not letting me click on anything in my presentation because it's freaked out that I'm on stage. Let me try this one more time. Let me refresh everything.
Alternatively, you can, if you send it to me, I can project it too, if you'd like.
Okay, I will try both of those things. It logged me out of it now. I'm incredibly sorry.
No problem. I'm putting my email in the chat there. You can, there we go.
I will work on logging into it, and then I will try to send it to you. I think that might be helpful.
Okay.
Appreciate that. I'm also happy to just talk about my idea, but I really would like my PowerPoint.
It's beautiful, so.
Okay. Okay, almost. Let's see if I can copy a link to this. Aha, get shareable link. I feel like somebody's very tech illiterate professor, even though I'm not tech illiterate at all. Okay, yeah, I refreshed it a couple times. Thank you. I'm going to email it to Tracy here. One moment. It's trying to load my email at the same time as. Okay, there we go. I borrow a Chromebook from my school that is very lovely.
Do you want to try and share it one more time?
No, it's loading. I hit compose email and it is slowly bringing that up. So I should try to start a presentation on top of that. I have a Chromebook that I borrow from my school, and I don't think it has ever had to use this much bandwidth at once before. I did not anticipate this. Let me see if I can email it from my phone. That is another idea.
That is totally fine too.
I wish I wasn't the last group left, because then I could just, you know.
No, don't worry.
It's like very frustrating.
This is a yoga stretch break for folks. No worries.
Yeah, okay, I'm glad. Okay, I guess I'm trying this on my phone, because my phone is working okay. Okay. Okay, now it actually pulled up my email, so we're almost there. Okay, I'm sending the email.
All right. I'll wait for it. While that's sending, do you want to try and see if we can share again? Just in case.
I really think that might crash my computer, so no.
Okay. Uh-oh. No worries.
It is like gonna take a minute to send my email. There, it's sent. Yay.
All right.
Thank
Something
you,
just came. I'm so excited.
Yes. I have been
All
up too
right.
long for this. Okay.
All right. It's loading. All right. How's that?
Do not see anything on my screen. Does do other people? Because I probably can view the normal view of my own, just not in present mode maybe, but I do not see it on the screen.
Unable to see it either,
All
Avi.
right, I'll try one more time. No, it wasn't. It might,
Oh no,
might
the
be a
chat can't
Canva
see it
thing.
either.
Now I'm actually really curious.
Yeah, yeah.
Let's see.
So you have to, when you share screen, you have to if it's in a different tab. Okay, now it's loading something. That's promising.
Is this it? I think it's it.
I think so. Yes, it is. Okay.
Yay! All right.
Yay. Awesome. Now I'm like, should I be high maintenance and try to pull up my presenter's notes? But I'm like this close to just not having my presenter's notes, because that would be.
Okay.
Is there? Can you see an option on?
Let's see. So I have these. I have the ability to kind of go up and down. But do you tell me when to advance, and then you can look at your speaker notes.
That's
All right?
perfect. I'm going to try to pull up my presenter's notes on my phone, but if I can't do that within 1 minute, I'm kind of done attempting to do things.
You got this.
Recent designs. Oh, I got it. Okay. Got it on my phone. So I'm thinking I can get my notes. Aha, beautiful. Okay, I have my notes. Thank you guys.
Okay.
Thank you for your patience.
This
Okay,
is small
and-
interactive. Are you ready to roll?
Yes, I am ready
Okay.
to roll.
Just let me
Okay.
know when I should advance.
All right. I already introduced myself, so I'll just skip that part, which is nice. Today, I have a proposal and a wake-up call when it comes to hacking the overdose crisis. It doesn't matter how evidence-based a resource or tool is on paper. If it isn't the kind of space marginalized people can easily access and feel comfortable and safe existing in, it will not be enough. Drug users have high rates of trauma and alienation in traditional healthcare and social workspaces, which too often drives us away from needed resources. You cannot problem solve around overdose without making humanizing, resource-rich spaces for active drug users that affirm our autonomy, dignity, and diverse needs. Today, we will present our model to build a community harm reduction center that unapologetically centers the immediate needs of illicit drug users, meeting us exactly where we are and pushing the envelope over time on what services we can access in that space. And we can advance to the next slide. Thank you. Where did my notes go? Okay, so this is our model based in Portland, Oregon. And the kind of point to entry that we would like to put on the map, the accessible goal would be a peer-led drop-in center with a mass spectrometer, which, if anyone is not familiar, a mass spectrometer is a device that is used to test the contents of drugs. Often they're in the possession of law enforcement or other regulatory entities, but we want them in the hands of people who use drugs. So the reason why this is our entry-level goal that we think we could accomplish within a year is largely because of our decriminalization measure 110, which both means that there would be few legal barriers to a device that would involve people bringing drug paraphernalia or residue in their possession. So there's less of a legal barrier, and Measure 110 also provides funding and grant opportunities for recovery and harm reduction services. So even in the absence of requesting resources like this, there are avenues to funding, and there is also precedent. Peer-led organizations like Chicago Recovery Alliance, and most recently, as of Overdose Awareness Day 2021, the Urban Survivors Union in Greensboro also has a low barrier mass spectrometer. We plan to grow with this space if we can create something peer-led like this and very low barrier. Safe consumption spaces are something we have our eye on now that we have a decriminalization measure. So there are multiple legal avenues. Many people are familiar with trying to get congressional approval at the state level. We are also interested in pursuing a research exemption so that we can maybe bypass some of the congressional gridlock. And we have allies in the drug policy research world who are very keen to help us actualize that, as they have experience working with research exemptions and safe consumption spaces in the United States. So the coalition exists for it. And our Measure 110 funding and other state funding foreshadows it, with categories such as harm reduction services that are very open-ended on purpose in order to make space for resources we do not have yet. So this is a medium-length goal that we hope to accomplish within a couple of years, but we really want to push to get that as quickly as possible to save lives. And then our kind of reach goal, that is kind of our dream, is to imitate what happened at Insight in Vancouver during the pandemic, which is that some opioid access treatments that were expanded became able to be prescribed on-site at Insight in Vancouver. This is also known as safer supply prescribing. And if we already had a research-based safe consumption site that was functionally running, this also is the kind of thing that we could pursue research on as expanded opioid access treatment. So our idea is just a full spectrum of low barrier harm reduction care that starts with this very simple drop-in center, community center model that can start out housing something within immediate reach like a mass spectrometer and can kind of graduate with our drug policy journey. We can go to the next slide. Thank you. I want to emphasize what I mean when I say low barrier, because we can say low barrier and we can say peer-centered, but what that means is that when people access a community center like this, they're at a point of entry. They're about to walk through a door, and on the other side of that door is an ecosystem of harm reduction resources. If there is some form of barrier or obstacle or stigma or ulterior motive or anything that makes it hard to access this doorway into services, there's that whole ecosystem of services becomes inaccessible to people. So low barrier to us as people who use drugs and the evidence base tends to mean a few things. Free of financial barriers and also locationally accessible. This means we have to take into account racial and class disparities of where things are located and how they are accessed and how they're advertised. It needs to be person-centered, which means that we are not prescribing goals onto participants. There are a whole spectrum of people who have different relationships with substances, and we want them to be able to define their own experiences and goals in an autonomous way that has been shown to help people create self-effective change. We also don't want there to be like a predetermined diagnosis or specific treatment goal that's needed to walk in and access these services. We just want a comfortable and inviting environment that people would actually want to hang out in and get their needs met. And then when we say peer-centered or peer-led, but at the very minimum peer-centered, we mean staff has lived experience, and that can be current or past lived experience. Again, there's a whole continuum of substance experiences. That staff also needs to not have a precarious experience. In my work I cited how peer work can be very precarious. It can be underpaid and inconsistent. So we want our staff with lived experience to be well compensated and supported at work. We also want staff and participants with a spectrum of experiences to feel welcome, as I mentioned. We can go to the next slide. So I wanted to point out, after describing this very specific model, that this is applicable kind of anywhere. The principles I'm describing, I feel like a lot of people look at Oregon and they say Oregon has decriminalization, and that's why advocacy groups in Oregon are able to propose things like this. But all communities can use similar tools and steps to what I just described to build from the ground up, even if it's from different starting lines or focusing on different interventions in different spaces. Next slide. So this is the process we followed to make that slide that I presented prior with the Portland model that I have in mind. We started simple. What service could you house in a drop-in center if you proposed one today and you had about a year to implement it? What is there that doesn't have very big legal barriers and you could conceive of getting funding? So if I'm in Arizona, which just legalized needle exchange for the first time, I might be thinking about a peer support centered needle exchange. If I'm in Rhode Island, which is having to obviously implement a very medicalized regulated model, I could still be looking at what other organizations I could collaborate with on the ground. And I could still be looking at how to make sure that even in a highly medicalized regulated environment, my safe consumption site is low barrier and involves peer support in some way. I think this is why it's important for us to be able to have conversations in different states that are doing this work. You can figure out what support model could peers do, what kind of work could peers do, and what kind of work could allies from institutions do, which leads into networking. You find out who is a gate opener instead of a gatekeeper, what community stakeholders and professionals can act as allies, can tie into your program, and then identify quality wraparound services in other parts of the local ecosystem. Again, you're opening a door not just to the building that this is located in, but a whole continuum of care. And then the exciting part, building and scaffolding. Take advantage of the momentum of drug policy. If you have recent legislation or funding or policy regulations that have weird open-ended wording about overdose prevention or opioid crisis response or harm reduction, you can define that with things that have not yet been authorized and use that existing resources or the space that's been carved out for that to push for new resources to be authorized. Take advantage of the research world. While there are certainly ways that the research world can be biased or take advantage of people with lived experience, it can also be a huge asset. And there are ally researchers, researchers who are very harm reduction literate, and researchers with lived experience. And finally, put harm reduction values first. Those are our ethical boundaries and guardrails. When we build and scaffold like this, we access power from systems and credentials. And we need to look at, like, are we accessing that power to remove unneeded barriers, or are we accidentally creating more of them? And if we're doing that, is it worth it to be accessing that next step of power or resources if it's actually going to shut people out from what we're building? So that is what Oregon is thinking about when we're designing the things we want to implement. And that is what we hope everyone else in other states is thinking about too, regardless of where you are. It's kind of like meeting you in your area where you're at, just like we're meeting participants where they're at. And next slide. And this is just my references where I cited studies on the different interventions I mentioned, as well as studies about some of the precariousness and exploitation in peer work that we don't want to see represented, and as well as the necessity for things to be low barrier and some of the reasons why people who use drugs have a hard time in spaces that have certain barriers, and how that kind of prevents them from accessing overdose prevention. So thank you for your time. I hope that you can see overdose prevention as an ecological and whole systems thing that requires many resources, and this is just one way that we're thinking of doing that. Thank you.
Excellent. I think the sharing worked. Yeah, great
I
job.
really appreciate you sticking it out and helping me with that.
Absolutely. So let's see. I'm going to open up questions for from the judges, and feel free to again raise your hand and come on stage if you'd like, or post those questions in the chat for the team.
Also, Peachy, if you have an answer to anything anyone asks, feel free to unmute. I don't want you to feel like you can't unmute.
No, I love that so much. I was actually typing. For some reason, Avi, I can literally only hear your mic. Like, I can't hear you, Tracy. I can't hear anyone else. I can only hear.
Oh, wow.
I
mean, that's good to know.
Once this is done, but if there's anything in the chat that anyone wants to ask, I can read it. So that's a thing. Okay.
Yes.
Excellent. Let's see. A question from Brandon.
Oh. Hi, this is Brandon. Fabulous. Such a fantastic presentation. Thank you for sharing. I love the term drug policy journey in particular. I'm going to save that. I was wondering if you could just talk a little bit more about the Measure 110 funding mechanism. Who holds the purse strings there? Is there like a formalized process for requesting funding under that law, or is that yet to be determined? Sorry, I just don't know much about the Oregon context.
Can you repeat that question, please? It just now came through with the signal in the middle of your sentence. I
Oh
apologize.
no, okay. The question is, if you could talk a little bit more about the funding mechanism under Measure 110, like who makes those decisions? Is it like
Understood.
a state process?
Yes. So basically, Measure 110 allocated a certain amount of surplus tax dollars from the marijuana industry. After a certain amount goes to education and to law enforcement, there's a certain amount that ends up in the state general fund, and Matt just put the accurate percentage. That much of tax dollars is to go to basically this continuum of resources that includes treatment, harm reduction, recovery. Like they kind of broadly define it as care related to harm reduction. And so right now, the entities that kind of control that, there's our like Oregon Health Authority, and there definitely are like state regulatory pieces involved in it, but we also have an implementation council that is comprised of people from multiple organizations and community stakeholders, including some people with lived experience. There's that council is starting to form some different regulatory committees, and there's also just a general like grant application process for a couple different types of grants. For both. So Measure 110, I don't want to get too in the weeds here, but it one of the things it does is when you do get a citation for a small possession amount of a substance, you get referred to a potential health screening. You're not forced into treatment, but you can attend a health screening to get your citation and fee waived. And so one of the things that's being set up is people are applying for grants to become part of the network of support and assessment that happens at that stage. And then there's also access to care grants, which is just basically other services in the community that are going to benefit from the measure. And that's kind of more where a lot of different organizations are coming in to apply. So that's a bit about how it works. It's a little bit complicated, but right now is kind of when the floodgates are opening, and there's like a lot more money going into harm reduction than we've seen in quite some time. And they are actually making a pretty concerted effort, despite some tension, within the council. They're making a concerted effort, and so is Oregon Health Authority, to include low barrier organizations and peer-led organizations and kind of new organizations that have not been resourced before, so they didn't exist. So this is why organizations like the User Union and very low barrier organizations it's not just the formal nonprofit exchanges. It's really that was too much information.
No, that's outstanding. Go Oregon. Thank you for sharing.
Great. I think there's a question from Susan. I think everybody can see it in the chat, but she asks, can you please speak more about the product that will result from this project if it moves forward?
Absolutely. So the setting for this product is a low barrier community center that would be housed in Portland. That would, at very bare minimum, when we open it, we would want it to contain drug checking services. So it would contain a mass spectrometer, and so people could come in, and we would also want there to be like basic syringe access, like harm reduction supplies there, so that people can pick up, naloxone, or pick up alcohol wipes or whatever else they need. But mainly it would be a place where people could drop in and get the content of their drugs checked, because that goes beyond fentanyl test strips. It goes beyond some of the more subjective tools that we have that we're struggling to navigate this specific level of overdose crisis with. And then from there, because we have this particular landscape of resources, and because that kind of center is so versatile and kind of becomes a community space, it could really move to the next stage, whenever we access something new that we were not allowed to do before. So for example, if we were to team up with a research team about a low barrier safe consumption site, that could be housed in the same building. So you could have people coming in, seeing what's in their drugs, and accessing safe consumption services, which, as a lot of people know, are also tied very closely to wraparound services and referrals. And so again, it's this, we're trying to create a stable point of entry into a continuum of harm reduction care that it's casting the widest net, where people who want nothing to do with general recovery assessments might walk in off the street to see if their cocaine has fentanyl in it, or what their heroin is made up of. And those people can truly access just immediate needs, immediate harm reduction needs. And then if and when they have any interest in anything from medication-assisted treatment to just general healthcare, trauma counseling, like housing, that's the kind of thing where we build relationships with other community stakeholders, and we set up this kind of we connect ourselves to this ecosystem. And yeah, some of it we hope to level up within the building itself. We would love to go from being a drop-in center with a mass spec to a drop-in center with an SCS. That would be amazing. And, I even included kind of our pipe dreams, which we hope are not pipe dreams, which is that eventually that SCS could host some form of expanded OAT on site, looking to our neighbors up north in Vancouver. But that's basically the idea, is that it can grow from the inside in that space to offer more harm reduction services, and also could link to the larger ecosystem on the outside. And I saw that you followed that up in the chat with, how could you help this model be applied successfully in other states? So 2 things. One, Tracy and I and some other people from COBRE and from other teams were talking earlier, and one of the things we talked about was how important it is that we get together and have collaborative conversations. So it looks like Rhode Island is having some similar, just big changes happening in their state with harm reduction access and with changes in legislation. I think it would be great if there were more chances like this for me to sit down in a state that's having these really tenuous policy changes with workers in another state. I was just talking with another peer support specialist who is kind of going through a similar changing drug policy landscape around her on the other side of the country. And I think that even just in that 30 minutes, we put 2 and 2 together on more issues than I really knew we would have in common, and got to kind of unpack that. So I think that's part of it. And I'm just starting to learn that COBRE has some resources that really center that and bring people with lived experience to research and collaboration. And so I'm interested in that. I also just want to emphasize, from the perspective of someone who's in a drug user union, that harm reduction activism has a long history of using this specific kind of method in basically every state and every part of the country. Not quite every state, but even in states that are tougher on these issues, there were harm reduction organizations pushing to do low barrier needle exchanges before public health wanted to touch it. There have been it's kind of about finding where your state is at, just like we're meeting people out in the world where they're at. It's finding where your state is at in the drug policy space. And like I said, if you've just legalized syringe access or just decriminalized syringes even, there's probably something that you could put in a low barrier community center model that could provide harm reduction services. And then as you and other community stakeholders are pushing for further legalization or decriminalization of harm reduction services, that space could grow to house those. And so it's that kind of thing where I just really want to see people, wherever they're at in their state, take what they have and hit the ground running, and basically support peer-centered interventions, support low barrier spaces, even if those spaces, even if there's very little that's tangibly legalized, but you can just have non-judgmental peer support spaces that are helping people navigate the resources that do exist. That kind of makes all the difference, where people just feel humanized and they feel like they're talking to somebody who recognizes them and who's trying to help them navigate the barriers, even if you are in a state with a lot of barriers. I think that makes all the difference. And then as you start to knock down those barriers by building coalition and through all of these ways we tackle that, whether it's policy or research or direct service in various ways, that only when you've already established those spaces, even in under-resourced conditions, they can just grow, and any resources they do get, they can take and run with. I'm sorry if this is a bit analytical as opposed to like numbers, but that's what the mentorship that I've been connecting with, who's been doing this work since the HIV/AIDS epidemic, has kind of instilled in me, is that we take what we have and we center the people who are benefiting from the work, and we center lack of barriers, and we run with it.
It looks like Peach also, yeah.
I see a question. Yes. Can you talk a bit about how you see the centers addressing racial and ethnic disparities? Yeah, so two things. I definitely don't want to have a white majority peer support staff. I think that would be replicating a legacy that we don't want, especially in Oregon, which has some issues with being a very white majority state, especially in social work and human services spaces. And we have to be really conscious when we're helping people navigate like family and housing services that like participants who are racialized are going to have a very different experience. So it would be like, just like we care a lot that peers match, like for example, if my relationship to drugs doesn't look like total abstinence from all drugs, I want to see a peer who kind of mirrors my specific experience and is stable and is thriving in their life. It goes the same for like, I would not expect a person of color using drugs to feel like I am their peer in quite the same way. And that's a place where I have to be humble and go, okay, I want to make sure if that person does not feel like I'm their peer in the same way, that they can open up to me about how the war on drugs has affected them as a person of color, like that they have representation within the organization that they can go to, even if they can go to me about other things, and I would obviously try to make myself continue my, I keep saying myself because I'm a peer support worker, so I envision myself working in a place like this, but like I also want peer support workers of like all backgrounds to have access to like professional development and continuing education in issues like this, because again, I think peers sometimes get relegated to a very precarious place where they're not getting professional development. They're just kind of stagnant in a role where they're being exploited. I want peers who work at a space like this to constantly be getting access to educating themselves and learning more and getting better as like providers of services. And that includes cultural competency. And also we just have to make sure that we're not missing big things like where our center is located and how we advertise it, and like language accessibility. Like it would be really easy to try to be very culturally competent and completely miss translating our concept to communities who could really engage with it. So again, I feel like it's really important to have people working in and around the project who do not speak English as a first language, who are not white, who are Indigenous and Black and Hispanic. And I think that that's something that, especially in Oregon, we really need to grapple with as we create spaces. Thank you for the question.
Wonderful. This is great. I think we're going to tie it up. This was an amazing set of presentations for everybody, and a phenomenal way to end. Sorry for the technical difficulties, but we made it work. The judges have a hard job. We now need to bed backstage to our other space. I'm not a judge, but I will be helping to facilitate that conversation. But we're looking forward to a longer conversation. And I think stay tuned. Obviously, you're welcome to hang out at any of the tables if people want to chat further. If not, enjoy the day. It's beautiful, and come back around. We'll post on the feed when we're set back. And I believe, Michelle, if you want to just push, do the math and figure out what time based on when we're ending, I think we're hoping to gather back again at around, I believe it's 4:00. But please correct me if I'm wrong. But please come back around, check back in maybe at 3:45ish and see, we'll post how we're doing. Oh, and reminder, just teams, please email to Michelle your slides. I actually have your slides now, so don't worry about it for you guys. But everybody else, if you haven't sent them, please do so. Thank you all for coming. Maybe take a nap for like half an hour or so, an hour. All right, we'll see you all very soon for the unveiling of our teams. Thanks so much.